Okay, well, we might talk about some of the weak opioid drugs, whatever that term really means. These are drugs that should probably not be used in patients who've got significant cancer pain. So it's sort of that next step on from simple analgesics. One of the problems is, and I guess I'm thinking of codeine here, and it's not that I think codeine is a bad drug, but I think there are better alternatives than codeine if you think someone needs an opioid. Having said that, we all know that Panadine and Panadine Forte are, some of the biggest selling tablets in the country. But there is a tendency once these drugs are started that people just sort of continue on with them and push the dose up a bit more and a bit more rather than moving on to stronger opioids in small doses. Obviously these drugs are quite popular. As I said, they're widely prescribed, but they're certainly not devoid of significant side effects, and I guess constipation springs to mind. So I guess the drugs that are sort of put in this category are things like codeine, which is methylmorphine, tramal or tramadol, and probably less commonly these days, dextropropoxyphene. Codeine is a naturally occurring opioid. It has about 10% of the potency of morphine, so that's important to remember just when you're converting from codeine to morphine. It's not a long-acting drug. Its oral bioavailability is similar, I guess, to morphine, maybe a bit more than morphine. It can certainly be used as a antitussive and is good as an antidiarrheal drug. It's got a much smaller affinity than morphine has to the mu or morphine receptor. The other thing to remember about it is that there's a group of the population who really don't get much benefit from codeine because they can't convert the drug. And there's a group that actually convert the drug too well, and so they can actually get toxicity if you're not aware of that. So someone who's actually taking, and I'm often surprised by patients who may be on a fairly substantial dose of background morphine, and they actually do prefer to have, say, Panadine or Panadine Forte as their breakthrough. So you come across those patients from time to time, and one wonders whether they are actually rapid metabolizers of codeine. In acute pain studies, codeine in combination with aspirin anyway has been shown to be more effective than either of the drug alone. I think in palliative care you've got to appreciate that people in general practice are seeing these patients usually a bit earlier than we are, and often the relief that they get from codeine earlier on can be quite good, and the drugs do suit the patients quite well. The only problem is once you get above 60 milligrams a day, it's said that you will start to get problems with constipation. So that's only 2 Panadine Forte. So my philosophy is that if a patient is referred along to me and they've got multiple symptoms and their pain's reasonably well controlled on Panadine or Panadine Forte or something like that, then I don't change it just for the sake of change. It's important to remember the laxatives, and I'll go over and over this like a broken record. And I find myself doing it sometimes. You'll see a patient in the clinic and you'll start them on an opioid, and then you'll think, bugger, I haven't talked to them, about, you've got so many other things you're thinking of and talking about how to take the drug and blah, 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 and then you forget to talk to them about constipation, i.e. you've committed a cardinal sin, basically, and when you've started them on a regular opioid. Favourite laxatives, we use just what everybody else does. So we start off with Caloxyl and Senna, and then we go to Movicol. So we're just as boring as everybody else. Just what do you use out at Canossa? You still use lactulose, okay? Yeah, we tend not to use lactulose. That's my feeling is there's Movicol people and there's lactulose people, and they're not the same people. So people who really have a lot of trouble and hate the taste of Movicol, often they don't do too badly on lactulose and vice versa. Epsom salts, yeah, you still see some patients who have Epsom salts, yeah. So yeah, there's nothing new on the horizon except methyl naltrexone. So that's the injectable one now, laxative. So, and that was pretty impressive because methyl naltrexone was in the New England Journal of Medicine. It's pretty impressive to get a drug for constipation that actually ends up being as an original article in the New England Journal of Medicine. So I was impressed by that. Tramel's been around quite a while now, so it's relatively new, but it's not new. So tramadol has this dual mode of action. So it's a weak opioid, and then it also has this effect on the descending inhibitory pathways. So it's considered to be a step 2 analgesic. And it's interesting, we tend not to prescribe it. In fact, we had a patient admitted this afternoon who was on 400 milligrams of Tramadol a day, come down from Caboolture Hospital, and actually it was an interesting combination. This patient was on Tramadol, Norspan patch, and Panadine Fort. This is an inpatient, so I thought that was an interesting combination of drugs. So we stopped all of that anyway. So step 2 drug, and as you all know, it's available as an immediate and sustained release form. And once again, the anaesthetists like Tramadol as a post-operative analgesic as well, so they seem to use quite a lot of it. But in palliative care, we tend not to use the drug. Once again, it's a European drug, really, a German drug. So the Germans like Tramadol. So it's got reasonable bioavailability. Its only metabolite is an analgesic itself. Like codeine, it's metabolized by the cytochrome P450 CYP2D6 pathway. The short-acting lasts, 5 hours or so, and so there's immediate release forms and there's slow release forms as well. So it's as I've already said, it's a weak mu receptor, but it does stimulate serotonin release. And parenterally, it's about 1/10 of the potency of morphine, and orally about 1/4 to 1/5. That's because it has a reasonably good bioavailability. And the doses can be pushed up to 600 milligrams. I've never prescribed that dose. As I say, I don't usually use the drug, but I've certainly seen patients on 200 BD as a dose. Side effects, well, the same sort of side effects as you get from opioids, I guess. Nausea. The dizziness seems to be an issue. Vomiting. It was sort of marketed that it didn't cause constipation, but it actually does cause constipation. And then there's this interaction that you can get with the SSRIs, so the serotonin syndrome. And there is an interaction with Tegretol as well. Okay, so this was a study looking at comparing it with morphine. Constipation, pruritus, and neuropsychological symptoms were more common in the morphine group. Does that make Tramadol a better drug than morphine? I don't really think so. Dextro is related to methadone, so it's a synthetic opioid. It's not quite as potent as codeine, but once again, I usually use it as about the strength of codeine, because I think one of the issues is that you can get too hung up on comparing doses between the drugs. This is 12.2 times, and this gives you that. And, at work we sit down and we calculate doses and things. But once again, you've got to take into consideration a number of other things as well. So I roughly use it as equal to codeine, but it's probably not quite as potent. It's got a fairly long half-life, like methadone does, and that's one of the problems with using methadone. And it's usually given as a combination analgesic, so Capodex or Digesic, but it is available. And I think that's the hydrochloride form of the drug, but it's also available in the napsylate form as, I can't think of the name of the drug. They're 100 milligram, and there's just straight dextropropoxyphene napsylate. Diloxine, is it? I can't think now. So it may, that's the other one of the theoretical advantages, is that it might have less constipating problems than codeine. Adverse reactions, they're all the same. Chronic ingestion has been associated with, that's a pretty high dose really, isn't it? When you think, how much is in a Digesic tablet? 32.5, absolutely right. And 10 times paracetamol, so 325 of paracetamol. So taking 800 milligrams a day, you're popping a lot of Digesics, aren't you? Adverse reactions with other drugs have been noted, so once again you have to think about, is it reasonable to prescribe the drug if they're on lots of other different sorts of drugs. And I must say my heart sort of sinks when I see, patients and all the sort of different drugs. I mean, I think we're bad in palliative care because, we have patients on analgesics of different types, and then we have to put them on laxatives, 1 or 2 laxatives because of that, and then they're on antiemetics, and then they're on something else, and then you add that into all the other drugs that they might be on for their heart failure, their blood pressure, their hyperlipidemia, and their COAD, as well as their diabetes, of course. And it's just atrocious how many drugs that people end up being on. And sometimes the role in a palliative setting is to say, well, listen, what's absolutely vital to the symptom control of these patients, and then start pruning the drugs back. But often that's difficult not only for us to do it, but the patients think, well, I've been on, my Lipitor for, 15 years, doc. What are you trying to tell me, that I don't need it anymore? Is there really something wrong with me now? Well, yeah, you've got, liver mets and brain mets and things. You probably don't really need your Lipitor anymore.